Shared decision making could be seen as describing what GPs do every day, talking to their patients and reaching conclusions together. It's probably particularly valuable in the treatment of major depression because we know the outcomes are so difficult. 50% of people in Australia don't pick up their script for an antidepressant 3 months after they start it. And if we refer them to a psychologist, on average they only see them 3 times. We're not getting the message across about how bad depression can be and how we really need to persist with treatment to prevent ongoing disability. One of the keys to that might be engaging patients more in the decisions about their treatment. We do have some published evidence that shows it does make a difference. So a recent large Taiwanese study compared cognitive behavioural therapy and antidepressant treatment for major depression, and patients were randomly allocated. Before they were allocated, they asked what their preference was. They didn't necessarily get their preference, but at the end of the study we looked at whether did their preference make a difference. Actually it did. If you got the treatment you preferred, on the Hamilton rating scale you did on average 3 points better, which is about the difference between an active drug and placebo. Choice helps. Shared decision making in major depression does involve drilling down to what this patient understands depression to be, what's important in treatment for them, and reviewing it on an ongoing basis to make sure you and they are still in sync. There are several key things that are central to making shared decision making work. One of them is starting it as close to an equivalent point in terms of knowledge before you can have a proper discussion. So giving patients quality information about depression and its treatments is critical, and we probably don't do enough of that. Even before they come to see me, wouldn't it be great if a patient knew what are the likely issues we're going to discuss in the treatment of depression? What are the side effect issues, for example, that might be relevant in our choice of antidepressant? Some patients will be able to integrate that information better than others, but don't assume they don't have some. Sadly, many patients get poor quality information from the internet. How about we give them some quality information before they come, and our discussions will be better. That can be written, that can be oral, it will depend on the patient. Good to involve their family in that discussion, because they'll have views. It's also good to recognise that where the power balance lies in shared decision making will be something that will vary from patient to patient. So many doctors will say to me, "Oh, but my patient wants me to tell them what to do." Shared decision making might ultimately end up with the patient saying, "I will accept your recommendation 100%. That's okay. If that's an acceptance based on shared discussion and information, I still think they're more likely to actually do it than if it's simply you saying, "Do it because I say so." In discussing antidepressant selection with patients in Australia as part of a shared decision-making process, we have the advantage of some great local data about what patients think are the most important issues. Interestingly, we might assume it would be a concern about efficacy, but the evidence says in the patient who's prepared to consider an antidepressant, most of them think there's a reasonable chance it'll work. In fact, the information need is probably to indicate maybe we won't always get the right one first. Patients are also concerned about issues like cost and about dosing regime, but their main concerns are really side effects. And in a way they're right, because actually that's what probably differentiates our products that are available the most. It's interesting though, what are the side effect concerns they have? The commonest ones weren't the ones you'd think of. They were things like weight gain, sedation, dependence or addiction, a fear it'll change who I am as a person. They weren't the concerns that are actually the most common in reality, like sexual dysfunction. That to me would signal I need to both focus on the things they are likely to be already worrying about, and the ones that can really happen but they don't yet know. One of my key aims is to get a sense of which of these side effects is important to this person, and also to set a conversation such that if they do have things like sexual dysfunction, they'll actually tell me about it and we can discuss options, not do what so many people do, just stop the drug and never come back to see me again. One of the other issues to consider is the antidepressant I'm starting, how easy is that going to be to stop if it doesn't work? Patients are often concerned about withdrawal side effects from antidepressants. Generally, we can reassure them that with most of the newer antidepressants, they're not problematic, but there are differences between the antidepressants in the rates, and we might take that into account, particularly in the patient who's had a bad experience coming off antidepressants in the past. I think the key part of my approach in selecting an antidepressant is to find out first what are the issues that are important to this patient. I won't necessarily make my choice before I know that, because that will guide me strongly. The best antidepressant is the one this patient's actually going to take. Once I've got that knowledge, I'll combine that with my sense of what might be the most appropriate given their symptom profile, or what I would predict are the most likely side effects for this person, and combine them usually into a choice. Sometimes I'll have gained a sense that in this situation it really would be better for me, as it were, to direct the orchestra and give a single recommendation. But on other occasions, and in fact most, I'd be giving a choice. We could do this or this. Probably my recommendation would be this. What do you think? I find that most patients respond to being given that freedom well, even if they're most likely to accept the thing that I'm leaning towards. I think it is really important to acknowledge that our GPs are often under an awful lot of time pressure, and what you can achieve in a 7-minute consultation that might deal with more than one problem, it's tricky. I think it is important to acknowledge that these issues are worth devoting time to. There's a sense of investment that if you set this right in the first place, the chance of a better outcome will ultimately save you and the patient time in the long run. If you can't get it all done in one consultation, so be it. You're probably better off getting them back than rushing it. It's important to remember shared decision making is an ongoing process. So any outcome of a shared decision needs review. So a key part of this process is getting the patient back on a regular basis. So any patient with major depression, I think, should be seen at least 2 to 4 weekly during the initial phase of treatment, and perhaps during the maintenance phase that can gradually move out to, say, 3 monthly to 6 monthly. The relationship, though, is central. People are more likely to do what we'd like them to do if they have confidence in us. If we don't have a relationship, guess what the outcome will be?